Now, the next question with regard to therapy, and we want to look at it in each of those settings, is just how long do you continue treatment once you start treatment on a patient? And just for the sake of getting into this in a relatively, oh goodness, I almost said in a way that we could all agree on. In the frontline setting, how long should therapy be continued? You start down here, Rob?
Well, I mean, I think in frontline setting, I usually will treat to 6 cycles. I mean, that's.
But if you use Bev?
If I use, yeah, you mean for the duration, if we have access to Bev, then we would use it like 218. So we'd use it for a total of 22 total cycles.
So that
15 months.
In essence, 6 cycles of chemotherapy, and then followed by bevacizumab maintenance if you use bevacizumab.
Well, concomitant, just like 218 in the experimental arm. So
And
the
would you
concomitant with chemo followed by Bev.
And would you use any other form of maintenance if you weren't going to use bevacizumab?
You know, currently I don't off protocol, but certainly there's good, you know, we have a good discussion about paclitaxel, and certainly the 212, when it matures, which will be several years from now, we'll have a cleaner answer about whether or not that's of value.
Okay, and GOG 212 is a study that looks at the use of maintenance paclitaxel to either confirm or refute our earlier data.
The earlier data from 78.
Very similar to Rob. If I use Bev in the frontline setting, it's for those 16 additional cycles after frontline therapy.
Okay.
Same.
Tom?
I treat until progression.
Frontline? With bevacizumab?
With Bev.
As a maintenance, yeah, okay. Yeah. All right.
And in the high-risk group, where they're essentially all going to recur, that's not unreasonable.
No, that's what we did.
And you might ask why I do that. And if
Yeah,
you
why
look
do
at,
you do that?
if you, thank you. If you look at the progression-free survival curves from ICON 7 and from 218,
Yeah.
I know, but it is interesting. It's right when you stop that you see that sudden tick down to where those curves start to come together.
So no one will accuse me of trying to play the role of protected moderator again. In the frontline setting, we treat with 6 cycles of Taxol, carboplatin, bevacizumab, and then follow that with bevacizumab maintenance until progression. All of the data, in my judgment, support the idea that once you stop the bevacizumab, there is a degradation in the difference between Bev and non-Bev arms, so that it at least says to me that anti-angiogenic therapy in that form probably should be continued indefinitely.
And to be clear, the bevacizumab starts cycle 2, so the first cycle is without bevacizumab to allow healing.
You know, my only concern about that strategy is that we know that there are patients who met the eligibility criteria who are never destined to recur.
But that's why I give it to the high-risk group.
I know, I understand, but I'm just saying, if you're treating all comers, you're going to be treating patients for life.
That's right.
I understand,
well,
and at some point...
What in actuality happens, though, is once they get to
and they're
18 months, 2 years, or what have you, I mean,
they become intolerant.
You start looking for reasons to...
But then you're treating them to an intolerance. I mean, that's...
I think in the maintenance setting, it's so important to understand those. They're not having symptoms from their cancer.
That's right.
That's
and
correct.
You're probably interjecting more symptoms from a maintenance strategy. You're making them come and see you every 3 weeks rather than they don't see you for 3 months. And there's a toxicity to that in terms of financial toxicity and them having to get on the road and come visit you in clinic and pay for parking and take time off of work.
Yep.
And that's important.
But
it's beyond.
But you're counterbalancing that against the only opportunity you have for cure is in the upfront setting. Not the only, but virtually the only.
So
and so think about that.
Don't know if Bev's going to increase your cure rate.
Well,
I think that's difficult to
We certainly don't have data to support that based on OS numbers. However, if you look at Gurley's data that we alluded to earlier in terms of signatures, and you actually have some patients that are being harmed by being on Bev, and you have the immune phenotype, versus the vascular phenotype, and if you would take those patients out, I mean, you almost have to argue that those patients would probably do tremendously better if you had that data. So, I mean, I think we have to think about it.
Yeah.
Bottom line is that the appropriate duration of the bevacizumab therapy in frontline setting is at the present time an unsettled issue. Is that a fair statement?
Fair.
Okay.
So we haven't really done very much in the frontline setting then in terms of agreement.
Paclitaxel
That's
carbo.
the disagree.
Talk about
Paclitaxel
elaborate.
carbo.
It's,
Well, I think there's-
all I can say to that is the moderator can only do so much.
But I think there's another
fail.
important point here, and I'm just going to move into this in terms of we have to be able to identify the most appropriate patients to treat with BEV, and that's the missing aspect
That's right.
here. And
Yeah.
you talked about the Gurley data. You know, could there be clinical indicators that could identify patients most likely to benefit from bevacizumab? There's been some information about patients with ascites. Maybe ascites could be a marker to identify patients most likely to benefit. And several years ago, we worked with the GOG on GOG 218 data to try to develop a nomogram, and really couldn't develop a nomogram based on clinical factors, but I don't think we included ascites. And maybe now with some of the input coming from the molecular biomarkers, and the tissue-based studies that are coming forward, maybe we could add that all together to really develop a tool to select patients.
And in fact, Mike Beers reported at this
meeting,
their work in terms of looking at a number of factors and
Tissue
molecular things. And you know, as in the past, VEGF levels have been looked at, microvessel density, a number of different things. But now actually looking in at what mutations are associated with better response, and there's some hypothesis generating data that he's presented.
And for the benefit of the audience that may not be familiar with the Gurley data, you referred to it earlier, Tom. You want to just briefly?
Sure. So basically what they did was they went and tried to determine molecular signatures for patients, and I believe it was out of the ICON 7 group. And what they found is they fell into 3 different categories mainly. And what was very interesting is only the angio group really had a survival advantage from being treated. And what was even more amazing was the immune phenotype actually had a degradation in survival when they were treated with bevacizumab. So that's why I think it's really very interesting, because now we're not only saying this group doesn't benefit, what we're saying is that you're actually going to hurt this group by treating with this drug that does have toxicity and significant cost. And it would also explain, in my mind, because it never made sense to me, how you had a drug that clearly has activity going all the way back, Brad, from your early reports to 170, GOG 170D. I mean, BEV's story should have, in ovarian cancer, been the greatest success. It's a VEGF-driven disease. It showed independent activity. And yet it didn't create a survival advantage, and that to me was a surprise. When I saw the first 218 data, I was surprised. I was disappointed, because I wanted to see an OS advantage, and that Gurley data is the first thing that I've seen. And I agree that it has to be validated. There's a million things that need to go on. But point is, it's the first thing that I've seen that makes sense of it all.
All right, with that, and we'll come back to the issue of why no survival advantage in a number of these studies that we've talked about in just a little bit. But if we could bypass that issue for right now.
Okay.